they would have given MAC values of various anesthetic agents. And usually the MAC value, when usually they give at 760 millimeters of mercury or at 1 atmosphere at 20 degrees centigrade. So that's how they always give. And in a patient who is between 30 to 60 years, isn't it? You just see Miller or, whatever the textbook, they always, when they give MAC value, MAC of an anesthetic agent in oxygen in patients between 30 to 60 years and at 20 degrees centigrade, that is, sorry, at 37 degrees centigrade, not 20 degrees, the body temperature, 37 degrees centigrade at 1 atmosphere. Why all these things are important? Why 1 atmosphere is important? Why 37 degrees is important? Why 30 to 60 years is important? And why, in oxygen is important.
According to the, if we keep nitrogen, we will get decreased.
For the other.
Yeah, MAC value can change with whatever the diluting agent that you are using. If you are using oxygen, that is a carrier gas, or you're using nitrous oxide, so the MAC value will change. Yes, very good. That's why you have to be very careful when you're telling. One. And age and MAC value, has it anything to do with the age?
Yes, when the age increases, MAC requirement will get decreases.
Lower down.
Yeah, so in the geriatrics, especially after 40 years, every decade, 6% MAC value will decrease, isn't it? So in younger individuals, so the MAC value will be higher. That is why the age is also very important when you're writing down what is the MAC value. And 37 degree temperature also is written there. Is MAC value changes with the body temperature?
Yes, sir. In hypothermia, MAC value will get increases.
Increase in MAC
Correct.
value.
Hypothermia,
it can occur with hypothermia. Yeah, that is another important thing. And again, the atmospheric pressure also is very important. Why atmospheric pressure is important?
Altitude changes will bring about a change in MAC value.
Now, how atmospheric pressure and MAC value are important. That's why in the definition of MAC, you always mention 1 at 1 atmosphere. Just to give an example of halothane, for example. Now, the MAC of halothane is 0.75, isn't it? So, when you convert it into partial pressure, how much it will be? 5.4 millimeters of mercury, isn't it? 0.75 of 760 millimeters. So, partial pressure of halothane, if you say MAC value of halothane is 0.75%, its partial pressure will be 5.4. And, suppose I take, I'm mentioning 0.7 of altitude of, or the, atmospheric pressure of 400 millimeters. What will be the partial pressure of 0.75 at 400? Roughly about, 3 millimeters. Instead of 5.4 millimeters, it will be 3 millimeters, isn't it? Because, it is a partial pressure is important in producing an effect rather than the concentration. So if you take halothane to an altitude area of 400 millimeters atmospheric pressure, and if you have the 0.75% output, it will not produce the MAC, or in 50% of the individuals, it will not produce any, the state of unconsciousness or, prevention of movement. So it will be much lower, isn't it? Because the partial pressure is important more than the concentration. That is why whenever you are mentioning the MAC value, it is always, you have to mention that it is 760 millimeters of mercury. That's why instead of MAC, now what they are telling is the MAP, MAPP, MAP. What is MAPP MAP? It is a minimum alveolar partial. If I say minimum alveolar partial pressure of halothane is 5.4, so if you can produce 5.4 millimeters of mercury of partial pressure of halothane at any place, whether it is hyperbaric chamber or high altitude area, as long as 5.4 millimeters of MAP is there of halothane, it is going to produce the same effect wherever you take. That is why nowadays people are going in for MAP instead of MAC. I hope you have understood the difference between MAC and MAP. MAC is the alveolar concentration.
Yes,
But concentration is not very important. Partial pressure is more important. That's why now they are going in for MAP, that is minimum alveolar partial pressure. So when you're talking about the definition of MAC, you always should tell about at 1 atmosphere. So suppose if I want to tell about the definition of MAP, I need not have to mention the at 1 atmosphere or half atmosphere, or need not have to mention about atmospheric pressure, because I'm already mentioning the partial pressure. That is why the MAP is more important than MAC. So these are some of the important things you should always remember about. And the other important thing about the MAC is who actually introduced this concept of MAC and when it was introduced. MAC concept was introduced in 1972 by Eager, EGAR. So Eager introduced this concept of MAC. So why actually he introduced this concept of MAC? What is the importance of MAC?
To check the
potency of the anesthetic agent varies.
And the MAC
Higher the MAC
increase,
value,
lesser the
potency.
Correct. One thing is, by knowing the MAC value, you know the potency of the agent, isn't it? Lower the MAC, higher will be the
higher the potency.
potency. Okay. If I say MAC value of, say, desflurane is 6 and MAC value of isoflurane is 1.2, which is more potent?
Isoflurane is more potent than
Isoflurane is much more potent than definitely desflurane. So one is to know the potency of the individual agent. Okay. What is the other important thing about MAC?
Lipid solubility.
No, it depends on the lipids. So, or oil gas partition coefficient. So higher the lipid solubility, lower will be the MAC. That is there. No, but why a MAC value? One is potency. Potency depends on lipid solubility. And very important thing, other thing is to compare different agents. Because you can't compare one agent of, halothane with isoflurane. Unless I say at 1 MAC. If I say at 1 MAC, I'm comparing halothane and isoflurane. Equipotent doses or equipotent concentrations I am comparing. So mainly in order to compare the different agents for their pharmacodynamic effects, so MAC is very, very important. You understood, isn't it? So these are the two important things about MAC. And of course, there are various kind of values are described, isn't it? What is MAC 95?
It should produce should not minimum alveolar concentration of the anesthetic gas should not produce skeletal muscle movement to the noxious stimulus in 95% of the population.
Yeah, it is almost like ED95. Otherwise, MAC is ED50. It is ED95. What do you want, ED50 or ED95?
95.
Yeah, because
95.
Isn't it? So
maximum
ideal would be, MAC is much lower when compared to the MAC 95, because that is the one which you do not want any patient to move. If you're using only the inhalation anesthetic agent, that is one definition is very important. Another is the MAC INT or MAC int. What is this MAC int?
The minimum alveolar concentration of the inhalation anesthetic agent that is required to not produce any response to any intubation response.
Not
Um,
intubation.
అది MAC
in
intubation.
I,
అది INT.
MAC int, which can produce good intubating conditions and good relaxation of the muscles, and larynx is totally not moving. It is that the concentration at which intubation can be done without patient going in for laryngospasm or any other problem. So that is MAC int. And how much is the MAC int actually? How much is MAC 95 of MAC?
1.5 MAC intubation.
1.2,
MAC intubation 1.5.
1.3 is MAC 95. 1.2 times or 1.3 times the MAC value is MAC 95. Whereas MAC int is how much?
1.5.
1.4 MAC. And there is something called as a MAC bar. What is this MAC bar? BAR.
Could not produce a sympathetic.
No, what is BAR? What is BAR? MAC bar.
Adrenergic response.
Response to surgical stim.
Blocking of the adrenergic
Adrenergic
response.
response.
Yeah, blocking. BAR. Blocking of the adrenergic response.
Adrenergic response.
So it is the MAC value at which there is no sympathetic
1.
response to laryngoscopy and intubation.
Laryngoscopy.
So that is called as MAC bar. How much is the MAC bar when compared to MAC?
1.7.
1.5.
2, sir.
1.5. So just remember, 1.5 is MAC bar, 1.4 is MAC int, 1.2 to 1.3 is MAC 95. And one more thing is MAC awake. What is this MAC awake?
Minimum alveolar concentration at which the patients, 50% of the population would respond to verbal
Commands.
Yeah, so that is called as MAC awake, isn't it? Where there won't be just, the awareness will be lost. And below which the patients, the awareness will be there and they can open their eyes also. That is called as a MAC awake. How much is MAC awake of when compared to MAC?
0.3. 0.3.
Yeah, 0.15 to 0.3. It depends on the individual patient. So it is MAC, that is 0.15 to MAC 3 is MAC awake. So these are some of the MAC important things you will have to know about. And what are the factors which can increase MAC and what are the factors which can decrease MAC? Factors which can increase MAC.
Hypothermia, thyrotoxicosis, chronic.
Yeah, hyperthermia. Okay. Then
chronic alcoholic patients.
Yeah, very good. Patients who are chronically alcoholic. Then
increased CNS transmission.
Increased CNS stimulants.
Increase,
Patients are taking CNS stimulants like amphetamine, dextroamphetamine,
okay.
Yeah, cocaine. If they are taking some stimulants, so then MAC will increase. So what are the factors which will decrease the MAC?
Age.
Hyperthermia, age.
Age already we
Then the
discussed.
age.
So after 40 years, every decade, 6% decrease in MAC occurs. Isn't it? That is why when you are want to have your monitor, which is continuously monitoring the MAC value, you have to feed the age of the patient, isn't it? Based on the age of the patient, it tells you what is the concentration. You can call it as a MAC for that particular patient. Okay, so that is why age is important. So increase in the age or geriatrics, the MAC value will start decreasing. Then hypothermia already.
Anemic patients, pregnancy patients.
Yeah, pregnant patients, there is
reduced cardiac output.
Okay, hypolimic patients.
Hypolimic, metabolic acidosis.
Yeah, metabolic acidosis, any acidosis, whether it's metabolic or respiratory
Respiratory
acidosis.
Acute
Then,
alcohol intoxication.
Acute
yeah,
alcohol
acute
intoxication.
alcoholic patients. Okay.
Hyponatremia.
Hyponatremia, hypoxia,
Hypoxia. Hypercarbia.
hypercarb. That's what respiratory acidosis.
Acidosis.
Hypercarbia is respiratory acidosis.
Respiratory acidosis.
Yeah. So all these, so these are usually commonly asked for you in the exam regarding the MAC. Suddenly, when you say the MAC value, they'll ask you about a volatile anesthetic agent and you tell something, and then the entire discussion can be regarding MAC. So, and the MAC is always commonly asked as a short notes, isn't it? So it's better you know more about this MAC. So coming to the pharmacokinetics of volatile anesthetic agents, before going into the volatile anesthetic agents proper, when you open your vaporizer, so suppose you are keeping a particular vapor concentration for the vaporizer output. So that vapor concentration has to reach the patient at the same concentration, isn't it? Or it should equilibrate at the patient end. So what are the factors which will influence this? From the vaporizer to the airway, which is called as FI.
Amount of the amount that is being delivered to the patient, amount that is being.
Okay, one is the vaporizer concentration you are keeping. One factor. Okay, what are the other factors?
Uptake from the alveoli.
No. Don't go there. I'm still, from the vaporizer to the patient's airway. You're holding a mask or endotracheal tube till that, which is called as FI. From the vaporizer to the FI, or fraction of inspired concentration. What are the factors which can influence the equilibration? Which factor can delay, which factor can increase? So higher the concentration you are keeping, so rapid, more
induction will be faster.
Faster.
No, I'm talking about the equilibration from the vaporizer to the patient's airway, and from the airway to the alveoli, and from the alveoli to the brain, isn't it? So these are what is the factors which you have to discuss about. So from the vaporizer to the patient's airway, which is called as an FI there. So one is inspired concentration. So the vaporizer concentration. Higher the vaporizer concentration, faster will be the equilibration between the vaporizer to inspired concentration, FI. Okay, one.
Then circuit, sir.
Second factor.
Length of the circuit.
So volume of the circuit. Yeah, very good. So volume of the, so higher the volume,
then it will be time taken will be increased, sir. Time to equilibrate will be increased, sir.
Yeah, delay, isn't it? Which is called as a time constant also, we'll be using many times. You must have heard about time constant, isn't it? What is time constant? These are all the things which you will be reading in your textbooks. So that's why I wanted to discuss about this. What do you mean by a time
Fraction
constant?
of
Suppose I start with a fresh gas flow of 8 liters, and the total volume of the circuit, the bag, and the canister, everything is 8 liters. So how much time it will take for filling this volume?
1 minute.
1 minute. And this is called as the time constant. So the time constant is defined as the time required to complete a process, provided the process is a linear one. But majority of the times, the processes are not linear, they're exponential. So the process will not be completed in 1 minute. So it takes about 5 or 4 time constants to complete the process, isn't it? So that's how, it all depends on the fresh gas flow, what you are keeping, and also depends on the volume of the whole of the circuit. Suppose if I'm keeping 2 liters as a fresh gas flow and the total volume is 8 liters, how much time it will take for one time constant?
4 minutes.
4 minutes.
4 minutes, isn't it? But what has been found is with one time constant, it's only 67% of the process is completed. So in order to complete the whole process, it will take at least about 4 time constants. That means for equilibrating the vaporizer output concentration to the concentration at the airway, it will take about 16 minutes, 4 time constants, isn't it? If you are keeping 2 liters. If you are keeping 8 liters, it will take 4 minutes because 4 time constants are required to equilibrate. I hope you understood. Because whenever the time constant is there, with one time constant, only 67% of the process will be completed. So for the second time constant, 67% of the 33% remaining process will be completed. Like this, if you calculate, it will take about 4 time constants for 95% of the process to be completed. So if you are keeping 2 liters and the total volume is 8 liters and the time constant is 4 minutes, so it will take almost about 4 time constants, means about 16 minutes. The same way, if you are keeping 8 liters of fresh gas flow, the time constant is 1 minute. So you can definitely hasten the process by within 4 minutes. So that is why the volume of the circuit is important and the fresh gas flow is important. That's why whenever you want to start your anesthesia, you always keep a higher fresh gas flow. Then after some time, you will go for, say, after about 10 minutes, you will go for low flow anesthesia technique. So that is the importance of this time constant. One, this is very, very important. Or if I want to hasten the process, I can collapse the bag and keep collapsing the bag so that I'm reducing the volume of the circuit. Isn't it? So suppose the bag is 3 liters, total volume is 8 liters, including the bag. I have collapsed the bag. Now I have reduced the total volume of the container or the circuit to only just 5 liters. So I'll definitely hasten the process of equilibrating the vapor concentration at the vaporizer to the vapor concentration at the air. So that's how these 3 factors are very, very important for vaporizer concentration to equilibrate with the Fi. Fi is the inspired fraction.
gas.
Inspired fraction. Now this Fi has to equilibrate with the Fa. Fa is the alveolar fraction or alveolar. So what are the important factors within the lung itself?
Blood gas partition coefficient.
No, that is after the alveoli. Before from the airway to the alveoli.
FRC, minute ventilation.
Yeah.
Respiratory rate.
Yeah. No, minute ventilation means it also includes tidal volume and respiratory rate.
And respiratory rate.
So it is mainly the minute ventilation and FRC. These two are very important. Minute ventilation and FRC. If FRC is low, minute ventilation is high. So there will be a rapid equilibration between the Fi and Fa will occur. Isn't it? So induction can be faster. So where this can be, this kind of thing can occur, in which kind of patients?
Pediatric patients.
Very good. In pediatric patients, the FRC is
reduced. Minute ventilation will be.
Minute ventilation is almost double the minute ventilation of an adult. So why should you know about this?
To make
it can be.
In pediatric patients, induction will be faster when we increase the concentration.
So you have to be extremely careful in pediatric patients, isn't it? Because the effects may start off. They may get induced rapidly and the side effects also can occur rapidly. Isn't it? So that is one factor, the factors you should know about. And in any other type of patients, this FRC is low and minute ventilation.
Old age patients with
obese.
No, old age patients, minute ventilation is low, FRC is high. It is opposite.
Like
obese.
Where FRC is low, minute ventilation is high.
COPD.
Pregnant patients. Pregnancy, again, there is a reduction of 20% of FRC. Minute ventilation increased by 50%. So there also you have to be careful. If you want to induce them with inhalation anesthetic agent, they get rapidly induced. So that is another very important thing. And again, in older age group, it is nothing to do with these, though the FRC is high, minute ventilation is low, but still their MAC value is on the lower side. They may get induced faster. So that you should always understand. Now, the volatile anesthetic agent reach the alveoli. Now the alveolar concentration has to increase, isn't it? So what are the factors which can influence this FI and FA to equilibrate at the alveolar level?
Is concentration effect and second gas.
Uptake.
Okay, the other two factors are also you can always discuss is concentration effect and second gas effect.
Effect.
So again, already we have discussed about the concentration effect. Higher the concentration, more rapidly you can achieve a higher
Rapid injection.
the alveoli. What is the second gas effect?
When the anesthetic agent used with the nitrous oxide will augment the concentration of anesthetic agents.
Why?
Because of higher diffusion, solubility of N2O, it will get rapidly diffused.
Not solubility. Not solubility of N2O, but rapid diffusion.
Diffusion of the nitrogen.
It is almost 37 times more rapidly diffusible than nitrogen. It rapidly diffuses. So suddenly the amount of nitrous oxide in the alveoli will come down. It creates a sort of void there, so that more amount of gases can come from the circuit, enter the alveoli. Along with that, they also bring the anesthetic agent, and this is called as the second gas effect. No, from again the other factors which beyond the alveoli, what are the factors which can influence?
Beyond the alveoli, blood gas partition.
Yeah, blood gas solubility coefficient 1. Then and the amount of blood flow. Second is the amount of blood.
Cardiac.
Third factor is the concentration gradient between the alveoli and the pulmonary arterial blood. So these three factors are again important, because the higher any of these factors is higher, then the FI and FA equilibration will get delayed. For example, if blood gas solubility coefficient is higher, more amount of the volatile anesthetic agent will get dissolved in the blood. And so naturally, the FA will start dropping. FI and FA equilibration gets delayed. And the second thing is more amount of blood flow means more amount of volatile anesthetic agent is taken away from the alveoli. So again, FI and FA equilibration will start reducing. And the concentration gradient, if the concentration gradient between the alveoli and the pulmonary arterial blood is high, that is more volatile anesthetic agent is taken from the alveoli into the blood. So FI and FA equilibration will get delayed. Because, one thing you should always realize, we can easily measure the concentration in the alveoli, isn't it? FA, we can easily, or entitled concentration of the gas in the alveoli, we can easily measure. And because, the equilibration between the alveoli and then the blood and then the brain is very rapid, and whatever the concentration in the alveoli will be the same concentration in the brain. So since we cannot measure the concentration of the agent in the brain, but we can measure the concentration of the agent in the alveoli, because they are same. So it is the alveolar concentration which is very, very important. And if the alveolar concentration with the FI equilibrates faster, that means we can assume that the same concentration will be in the brain. Isn't it? Because FA and FB, let's say, the fraction in the brain are same. So naturally, you can easily measure the FA, that is entitled concentration of the agent in the alveoli. So that is if the patient, if the agent's blood gas solubility coefficient is higher, So the brain concentration or the partial pressure in the brain will get delayed. So naturally induction gets delayed. And if the blood flow across the pulmonary system is high, then again, that means if the cardiac output is high, again, there will be a delay. And if the concentration gradient is high, again, there can be a delay. So now we know that majority of our inhalation anesthetic agents, what we use, they have a lower blood gas solubility coefficient. For example, now desflurane is 0.4 and isoflurane, sevoflurane is 0.6. Among the three, isoflurane has got the higher blood gas solubility coefficient. So isoflurane will take a longer time. Suppose if you are using it as an induction agent, it will take a long time to induce the patient, isn't it? When comes sevoflurane and desflurane. Sevoflurane and desflurane. And many times, we'll be using either halothane or sevoflurane for induction because both are not irritants to the respiratory tract. And what is the blood gas solubility coefficient of halothane?
It will be higher, sir. 2.5.
Yeah, 2.4. So if I want to use halothane and sevoflurane, which one will produce a faster induction?
Sevoflurane,
Sevoflurane will produce a
So that is what, that is the reason why you should know about these factors which will influence the uptake of the anesthetic agent from the alveoli. These three factors are very important. One is the blood gas solubility coefficient, the blood flow across, that is the cardiac output. Third is the concentration gradient. So, and again, these factors are important for recovery also.
Yes, sir. Yeah.
Higher the blood gas solubility coefficients, delay will be the recovery because more amount of that will be there in the blood. So and also in the tissues. So it has to, enter back into the alveoli and to be excreted out. So because, recovery always depends on the excretion from the respiratory tract. So whereas sevoflurane and desflurane, recovery can be faster, whereas with halothane and isoflurane, recovery can also be delayed.
Slow.
Isn't it? Again, we are getting a message that we may, have the interruption of these things. Okay, so these are the factors which are very, very important as far as the uptake and distribution of the inhalation anesthetic agents are concerned. So that is very, very important. So let us go into the individual volatile anesthetic agents. Are we going to get a disconnection now?
Sir, yes, sir. Within 4 minutes, sir. Actually, it will be corrected tomorrow, sir, because I don't know what's happening, sir. It's getting disconnected, sir.
Okay. So what about continuation? Let us continue tomorrow then. Individual anesthetic agents.
Yes, sir. Tomorrow we shall continue, sir, because there is some disconnection, sir. So it is.
Okay. So tomorrow we'll go into with this. You read and come about this physics and the especially the factors influencing the uptake and distribution. So we'll just somebody has asked about the splitting ratio. What is splitting ratio? So splitting ratio is more important when you are talking about the vaporizer, especially in a variable bypass vaporizer. I was just discussing already. I told you that when you're using sevoflurane, so when you're passing about 79 ml of oxygen into the vaporizing chamber, it will pick up 21 ml. And what comes out will be 100 ml. Out of 100 ml, 21 ml will be the sevoflurane. And if the bypass flow is about 2000 ml, now total will be 2100 ml, including the oxygen which has gone into the vaporizing chamber and picked up the vapor of 21 ml. Now total percentage of the vapor will be 1% because out of 2100 ml, so we have 21 ml of sevoflurane. Now the splitting ratio is what is the amount of gas that is bypassed? So 2000 ml of the gas is bypassed. What is the amount of the oxygen that has entered into the oxygen or whatever the gas entered into the vaporizing chamber is 79 ml. So 2000 to 79 ml is the splitting ratio. It will be roughly how much it will be? 2000 to 79. If you just calculate 2000 divided by 79, just calculate.
25.5,
Yeah,
sir.
25 or roughly 25 is to 1 is the splitting ratio. You understood, isn't it? 25 to 1, that means 25 times is the bypass flow to the amount of flow entering into the vaporizing chamber. Vaporizing chamber 79 ml had entered, 2000 ml had bypassed, 2000 to 79 is the splitting ratio. Did you understand? Suppose if you want 2% of CO-fluorine, then how much of oxygen you have to make it enter inside? You double it, isn't it? Suppose if it was 79 ml, so you make it 158 ml, so it will pick up 42 ml. Okay. So now total you make it 2100 ml. So now you have got 42 ml of the CO-fluorine. So it will be 2%, isn't it? Now you have 2000 to 158 ml. That will be the splitting ratio. What will be the 2000 to 158 ml? If you calculate, you have a calculator now. 2000
by 150 ml.
158 ml.
13 is to 1.
Yeah, that will be 13 is to 1. It was 26 to 1. So if you want 2%, the splitting ratio varies. Like that, that is what is called as a splitting ratio. Now, if you go through any standard textbooks or even equipment book regarding the construction of the vaporizers, the splitting ratio becomes very, very important. And splitting ratio many times is also asked as a short notes. I hope you have understood now, isn't it? What is the splitting ratio? It is the ratio between the bypass flow and the gas that is entering into the vaporizing chamber. So understood, I think. Somebody has written yes, sir.
Yes.
If you have any doubt, we can also discuss tomorrow.